thanks for invitation, and thank you for this great privilege to present, I can't say our data, but just my vision. So, shall I press on something? No, but it's small. All right.
Такое.
No, thank you. For the,
Okay.
Thank you very much.
Left.
So first of all, talking about modern cardiac surgery, I must tell you that we have really great results, because I started my residency program already 30 years ago, and the results were different, absolutely. So in just one paper we just mentioned, we checked our results on almost 600 patients with mitral repair, and the repair was durable, everything was fine. But for me, most important was zero mortality. So hospital mortality 30 days from surgery or before discharge from the hospital was essentially zero. If we are talking about long-term results, they were also great. And I can tell you that in many cases for, let's say, normal patients, so it's 90% of our population patients, cardiac surgery is less risky within the first 30 days than cardiac catheterization. And this is news, so it's great news of last years. But still we have several great challenges, and greatest challenge, biggest and most important for me at least, and maybe for many other surgeons, is heart failure, end-stage heart failure, and mechanical circulatory support to assist for these poor patients. We know that it's many tens of millions in the whole world, 3% of adult population, and most importantly, up to 10% of patients above 65 years of age. And adult and I can't tell old population, but patients above 65 are getting bigger and bigger with years. And these patients are coming to my office before, after surgery. From time to time, they're 80 years old, and every day, 7 days a week, they go on to swim in the country, in the bath, everything. So population is growing. Results of medical and even inotropic in-hospital treatment of heart failure are very poor, very poor. And we have results of heart transplantation. So next slide will be that we have definite shortage of hearts for transplantation. So results are not so good. So till now, till these days, 10-year survival is around 2/3. So just 65% of patients 10 years after heart transplantation these days are surviving. And of course, we have significant shortage of donors, not only in Israel, in Germany, the same situation in the States. And the population of donors, number of donors, of heart donors, are not growing. And the only reasonable advice for this patient, the only method we can treat him is the implantation of left ventricular or maybe biventricular or right ventricular assist device, a part of artificial heart. And the only device we have now these days is just HeartMate 3 by Abbott. And it was significant changes since 90s when it appeared like HeartMate, first HeartMate, and then we have HeartMate 3. And now this morning I had a meeting of 2.5 hours with Abbott CEO and other representatives. They are working about much smaller device, HeartMate 3 Mini. So it will be a really small device. Another important, except of mechanical circulatory support, except of LVAD, it can be ECMO, extracorporeal membrane oxygenator, or impeller. It can help us to keep patients, and very difficult, just now resuscitated patients alive. It can be bridge to recovery, to heart transplant, or to LVAD implantation, because we can keep these patients alive for many months and years with LVAD, and ECMO can't help for a long period of time. This young boy operated in our institution with biventricular failure. We put him 2 LVADs. and he is doing absolutely fine. You see on chest X-ray 2 machines. Now this is HeartMate 3. HeartMate 3 Mini will be twice as less, half of this size. And this guy, he's going to gym 7 days a week and feels nicely. This year in Milan, we had the European meeting of cardio-thoracic surgery, and the most fascinating thing I saw, it was a totally implantable, total artificial heart by CarMate, only one company from France. And it is very interesting. And another issue, also very new issue, that we can, in the decommissioning LVAD, we can just stop LVAD without taking it out if it's not infected. We can just leave it in and stop its working if heart is recovering. So we have 3 patients like that. After 3 months, maybe a year and a half, heart is recovering. We can just use easy procedure on cath lab to close outflow the graft and cut actually cable. Patient is alive without LVAD, just small pieces in. Last slide, and Dr. Kasif is sitting here, my great colleague. It was a totally implantable left ventricular assist device. We had one patient like that, and totally implantable. This patient can swim, can take a shower without any problem, and his artificial heart or left ventricular assist device is totally inside. So, and also, Abbott, they told me now these days, so they're very much in it, So thank you very much, and I'm just 30 seconds before time, and thank you.
Thank you very much, gentlemen, and I will open it for discussion.